Okay, this was a 14-year-old male who presented with suprapubic pain radiating to his right testicle. It was accompanied by dysuria, urgency, and frequency. He saw his pediatrician earlier in the week, who noted a subjective fever. He appeared well on physical exam. He did a urinalysis, which did not show infection, and was subsequently diagnosed with viral syndrome. He was seen in the emergency department a few days later with worsening suprapubic pain, which he characterized as cramping 6 out of 10. He had a fever at home of 102.9 with dysuria, urgency, and frequency. He had no nausea, vomiting, diarrhea, or constipation, no penile discharge or STD concerns. He was not sexually active. He was tolerating oral intake. On exam, his vital signs were stable in the emergency department. He looked well. Skipping down to his abdominal exam, it was soft, tender, with suprapubic, periumbilical, and right lower quadrant tenderness. There was no rebound or guarding, no distress, no costovertebral angle tenderness. His genitourine exam was also normal, without any testicular or penis tenderness or swelling. The testes were descended bilaterally, and there was no hernia. So in the ED, he had a white count of about 15,000 with a neutrophil predominance, a normal metabolic panel and urinalysis. His pain was well controlled with Tylenol, and a CT scan with abdomen pelvis with IV contrast is pending. So let's talk about his differential here a little bit. Periumbilical, you see here, pancreatitis, early appendicitis, stomach ulcers, inflammatory bowel disease, umbilical hernia. You can also think about urinary infection down here in the suprapubic area, diverticular disease. In females, you'd think about reproductive tract problems. And then a right lower quadrant area here, you got a constipation as well, groin pain, hernias, and maybe you also consider kidney stones and pyelonephritis. Ultimately, this young man was diagnosed with appendicitis. Here's an illustration of the anatomy of the colon, and you see the appendix here hanging off the end of the cecum. What happens essentially is that something gets stuck in there. Usually it's stool or a fecalith, sometimes lymphoid hyperplasia, which blocks it. There gets pressure builds up. There's ischemia, swelling, infection, sometimes rupture. It's very common. It is the #1 cause of surgical emergencies with a slight male predilection. Famously, the clinical presentation starts with periumbilical pain that then migrates down towards the anterior superior iliac spine and is classically known as McBurney's point, which is about 2/3 of the way between those two landmarks, and can become more generalized if can develop peritonitis if rupture occurs or the disease progresses. Patients also endorsed anorexia, nausea, vomiting, much later diarrhea and tenesmus, and then fever is just too non-specific to rule in or rule out. However, 3/4 of patients will present with a, quote, low-grade fever. Physical exam has some sort of classic findings, especially tenderness at McBurney's point. Rofsing sign is palpation of the left lower quadrant producing pain in the right lower quadrant. psoas sign is you lay the patient on the left lateral decubitus and then try to irritate the psoas with the angry appendix, and you do so by bringing the hip into extension. Obturator sign or obturator internus sign, similar. You gotta get the appendix to land on the obturator internus, and you do that by flexing and internally rotating the thigh. Labs will typically show a non-specific elevation in the white blood cell count. X-ray was maybe used historically, however, now is not much of a high yield diagnostically. Ultrasound is probably the best choice in pregnant patients and children, as it is fairly sensitive and specific, however, will often be non-diagnostic, and that can be limited by body habitus. CT is a much better test, sort of broadly speaking, and useful to exclude other considerations like kidney stone or diverticulitis. You can evaluate the abscess better if there is one, etc. Downside is radiation, allergy to contrast, more expensive. Management is an appendectomy. There is growing evidence for a non-surgical protocol, however, that is definitely not standard of care and would need to be performed at the discretion of the surgeon discussing options with the patient. Perforation and rupture can happen. Those patients can get very sick. It's not very common. Abscess can be seen, which is typically drained percutaneously. However, there are other ways to get to the abscess. In the case of our patient, he did have a 7 by 4 centimeter abscess on his CT. So he was admitted to the hospital. He was put on IV antibiotics. Interventional radiology placed a percutaneous drain You see the drain here. The abscess is already sort of decompressed, but this is what a drain looks like on CT. He was discharged home on oral antibiotics 4 days later. And then after everything cooled off and healed, they did an elective appendectomy about 4 months later. So a few key points. The classic signs and symptoms of acute appendicitis consist of periumbilical pain that migrates to the right lower quadrant, along with anorexia, nausea, vomiting, and fever. The most common physical exam finding is localized tenderness at McBurney's point or in the right lower quadrant. However, they can have rebound, Rovsing's, obturators, or psoas sign. Diagnosis is typically made with CT or ultrasound, and most patients will require surgical intervention.